Hello and welcome to this webinar. My name is Jim Richards. I'm Professor of Biomechanics at the University of Central Lancashire, and I've run the Allied Health Research Unit here for the last 16 years or so. Now, in a lot of our work, we use EMG, using standard EMG techniques as well as decomposition EMG techniques. But one of the things that we've never previously been using is the high-density SEMG technology. So what I'm going to be talking to you today about is some recent work that we've been doing, where we've begun to look at the applications and usage of high-density surface EMG technology for the assessment of low limb stability and low back pain, or at least back muscles. But also, I'm going to be showing you some other very, very recent stuff that we've been doing, looking at wrist muscles as well. So a brief history of the Delsis Trinio evolution. Now, I started using the first generation of the Trinio sensors, and I can't believe it was 2008. It seems far more recent than that. But so 2008 was when this technology first came out, wireless technology, which then allows you to, in essence, collect data from a bipolar pair of electrodes or single differential electrode with an onboard reference as well, which meant that we didn't have to have the additional reference wire. So this was really useful. It moved away from having a kind of an umbilical cord, and having that whole wireless platform was particularly useful. On board, there was at that time just the gyroscopes, just the accelerometers at that time. And then there was a further development which involved the Trinio Mini, and then in 2013, the Trinio IM sensor, which also has the onboard gyroscope. So we obviously have this continued progression, development, which we've seen from the Delsis products. I've never used the Trinio snap wire leads and fine wire in my lab. We have seen it and used it in other labs, but this is not a regular thing we use. But we do often use the foot switches, which are part of the auxiliary sensor technology as well. More recently, we've obviously got the further development of the IMU and EMG platform, and also the Trinio Galileo, which we use for some of our decomposition work. But what I'm going to be really focusing on is the very latest release, the very latest sensors that Delsis have been producing, which is the Trinia Maze. So what signals can we record from our standard Avanti sensors? So what we get, generally speaking, is we get our EMG signal, and from the EMG signal we can do various processing on it, such as rectification of the signal, and then obviously some smoothing to get the envelope of the signal. So there's a couple of things that we can get from this, which we are commonly reporting in majority of our work, which is the maximum amplitude of a muscle activity, which we normally normalize this in some way, either with maximum voluntary contraction or maximum observed signal. But we can also get information on the onset of the signal. So the onset and offset, this is not something we've reported so many times in our papers, but many other authors have described the onsets and offsets in relation to different treatments and different patient groups when assessing EMG. So we'll cover that in a short while. So what we're dealing with here is a single bipolar or a bipolar pair or single differential. So you can see on the left there, I've highlighted the sensors that are actually recording the EMG, whereas the other two silver bars are associated with a reference. So again, this onboard reference, as I mentioned earlier. So what about the Trinia Maze? How might this be useful, and what is it? So the Trinia Maze we are exploring in my lab right now how we can use this to assess lower limb stability and what's going on with the motor recruitment, or the muscle activity, I should say. What we're also exploring is the concept of using this to look at muscle activation timing of VM and VL. So this is, again, recent work that that's currently underway. Assessment of lower back muscles is, again, something which is routine within our work, looking at how erector spinae is firing, or onsets and offsets, and magnitudes of firing of erector spinae, again, is a key part of our work. As I mentioned earlier, a recent thing we've been playing with is some multi-muscle activations across the forearm. So there's a number of ways that we can do this. We could do it with single bipolar electrodes or single differential electrodes, but we're beginning to explore how this might be able to use the Maze sensor for some of this testing. So let's take a closer look at the Maze. So what we get with the Maze is we get 16 channels of data. So we have these 16 channels. Now we can use two ways of getting a reference. You will see there's three horizontal silver bars down at the bottom of the sensor near where the wire attaches. These are local references, so we could have a local reference there. But what we are using is the global reference in the main body of the sensor, which I will highlight here. So this also contains 4 pins, which you can't see because of the positioning of the sensor here. But this also contains those not 4 pins, but 4 silver bars, which will act as the reference. So there's 2 ways of referencing this, which will depend on applications. But for this work, we're using the reference here, and then we are using these 16 channels of data. Now, from these 16 channels of data, we can get 12 single differential pairs. So what we can see here is that we're able to look at what is going on between this pin and this pin, and then from this pin to this pin, and then this pin to this pin. So we get a matrix array of, in essence, a 3x4 matrix of single differential pairs or bipolar pairs. Now, arguably, this allows for a greater spatial coverage, which you can then look at the amplitudes of the signals between these bipolar pairs without this idea of just having one long bar, which then potentially is going to be contaminated with crosstalk. So we've got more observations within the muscle over a greater spatial coverage. What we also get from this data is we get a greater number of observations of onsets and offsets of the muscle activations. And again, this might be useful for some applications. So again, we'll be exploring that in a short while. So let's pick up lower limb stability, or the assessment of lower limb stability in the first instance. Key muscles that have been reported associated with ankle stability or ankle instability are Perineus Longus and Tibialis anterior. There are many, many papers that have explored EMG on these 2 muscles. Now, we can test muscles in a number of ways. This is one common way of using a trapdoor and then look at the neuromuscular delay. So Perineus Longus is actually the really key muscle here. To a lesser extent, Tibialis anterior, but Perineus Longus is the one that we're really wanting to be focusing on with people with chronic ankle instability. Single differential electrodes may not necessarily give us a full picture of the muscle activity and timings across key outcome measures when we're doing this when we're doing trapdoor testing or dynamic stability testing. In other words, the muscle firing may not be exactly the same instant across the whole muscle. So if we're trying to calculate the neuromuscular delay and we're relying on one bipolar pair, then there is the potential that we will not be picking up the exact moment that muscle or the part of that muscle begins to fire. So this is where we're interested in perhaps taking a larger spatial sample. Another challenge that we have is identifying the location of the middle of the belly of long, thin muscles. Now, if we are thinking about the pins on or the bars on a normal Avanti sensor, or looking at other sensor technology, we are trying to get those bipolar pairs just so they are both proximal and distal within the main belly of the muscle at a set intraelectrode gap. And that set intraelectrode gap is very, very important. If we vary the intraelectrode spacing or intraelectrode gap, then we can easily vary the signal. Well, we will be varying the signal which is going into that sensor, and therefore we could be misinterpreting the data. So having a fixed intraelectrode spacing is absolutely critical in my view. How you fix that, whether it's 1 centimeter, 2 centimeters, but consistency is absolutely vital. So if we've got these intraelectrode spacing, we can now think, well, if we have that intraelectrode spacing, but we are in the wrong position within the muscle, we might not be picking up the first point of firing, or we might not be picking up the largest amount of muscle activity within that muscle. We might just be picking up an area, which is still going to be potentially representative of the muscle, but not necessarily representative of all of the muscles. So we're trying to increase the number of observations, as I said earlier, across the muscle. So one task that's frequently used when we assess chronic ankle instability is a single imbalance test with eyes open and eyes closed. Very, very common test to use. Thousands of papers that have looked at single imbalance, eyes open, eyes closed. So what we're going to do now is consider the data from the 12-channel high-density EMG electrodes from TA and PL. Again, because we've got 12, we are looking at the bipolar or single differential pairs. And the idea is whether we can see a clearer peak EMG from just some of the pairs, which would indicate that perhaps we're getting peak muscle activity in only one part of the muscle. Okay, so let's have a look at some data then. So what we're going to do now is we're going to place one Maze sensor on the tibialis anterior and another one on Perineus Longus. So here's our tibialis anterior, and we get our 4x3 matrix of EMG signals. So what this is referring to is that we are getting this pair here, which is associated with this signal. So this signal has come from this pair. This signal has come from this pair. So what we can see now is that we can then go along here, and in essence we are going in this direction, almost like the way we are describing this is if we're looking through the sensor with X-ray vision, then when this is placed on the skin, then that pair would be associated with that signal, and that pair with that signal. So we can then relate each of these within the matrix of the bipolar or single differential pairs. So what we've got here is Perineus Longus, and again we've got eyes open, eyes closed, and again we have the pair of electrodes here, the bipolar pair here, or single differential pair here, which is associated with that signal, and likewise again there with there. So what we can see here very clearly, and not surprisingly, the eyes closed, we get a larger amount of both tibialis anterior and Perineus Longus activity. But what we are interested in looking at partly is these signals. These are very, very different signals that we're getting from PL and TA. So what we can see is that tibialis anterior with eyes open, not much activity, whereas Perineus Longus we're getting a little bit more activity there. Go eyes closed, and we get a lot more activity in both TA and PL. But it's also the patterns of movement. So we can see that the patterns of movement there are different with PL and TA, as we would expect. PL is very much a postural muscle. It's firing to keep the person stable, whereas T8 is more of a prime mover. So what we're going to do now is look at this data in a bit more detail. So I'm going to focus just on Perineus Longus with eyes closed. So we're going to have a look at this data. So here we go. We've got our 4x3 matrix, which again relates to the bipolar or single differential pairs where within the sensor. And what we can now do is look at what's happening with this data. So I'm going to pick one row of data here. So let's look at this row. And if we expand this row, we can see that actually on one of the channels or one of the bipolar pairs, we are getting a much larger signal than the others. So we're actually, if we were placing the electrode here or here, we actually see a 30% greater muscle activation or greater magnitude of EMG signal with this location here versus here. And what we're describing here is the difference between this bipolar pair and this bipolar pair. So these are quite tight. So this is around about 2 centimeters between these two points here, there, and there between these signals. So we're not dealing with a large spatial difference between these two sensor locations, but actually this could have a substantial effect at our recording of what the maximum observed EMG signal is. So this gives us, as I was describing before, more observations of what's going on within the muscle. So if we were now wanting to look at an intervention, it might be that we are going to see a larger proportional change just within one of these channels, perhaps this channel here, which is obviously showing the greatest signal. So we might not know where within the muscle, within that muscle bulk, where we're going to get the largest signal. And with the Trinia Maze, we have got this, in essence, this ability to take a larger sample across the muscle, across the spatial representation of the muscle, which then gives us more data to be able to explore this in more detail. So that's on ankle instability. Now, another thing that's really been reported at length is vastus medialis and vastus lateralis in functional knee movement tasks, be it step descent, sit to stand, many different functional tasks, squats, etc., etc. And one of the things that we are wanting to do, once again, is get this sample of data from these two muscles to explore whether these muscles are firing differently. So we can assess the muscle activity during these knee stability or functional knee tests. So traditionally, this is what we have is somebody doing a step down with some of our data that we've collected in the lab previously. And what we can see here is VM and VL. So we've got VM on the top there and in the blue, and VL, which is in the red. And the question is, which one fires first? So this is one of the common questions that's asked within the literature. So vastus medialis and vastus lateralis are key when considering conditions such as patellofemoral pain and other dynamic knee instability issues. Much has been reported on the magnitudes and the timings of the muscle activity. So what we can potentially do if we had a larger sample, a larger number of observations within each of these muscles, we could get this larger concept of the spatial sampling. Are we seeing a good representation of what that muscle is doing from a single bipolar pair, or would a larger sampling be useful? And the other thing is looking at the sequence of the firing between VM and VL. If we are using one observation from one bipolar pair or one single differential pair within VM and another within VL, we are relying on that being representative of the exact firing of the whole muscle bulk. So again, a larger sample may be useful in this way. Also, there is an issue with the best placement of the electrodes. And again, there's been quite a bit written on this with potentially if the placement is slightly incorrect, then we may be potentially getting incorrect findings. So this is all down to the user placement of identification of the main belly of the muscle. So let's look at the timing of VM and VL. What's been written about that? Well, Wong and Nig in 2006 examined the effect of electropositioning on EMG recordings of VM and VL with respect to onset timing. And they revealed that different positioning of the electrodes over VL and VM affected the onset time, with VL relative to the VM onset time. And also signal amplitude was also affected. But what the main purpose of this particular work was to highlight the timing. Further that, Wong et al. Did a review of the literature and found that 6 out of the 12 studies that they found at that time demonstrated a distinguishable difference in the onset timing between VM and VL, with the remaining showing the contrary. So there's some debate of whether VL fires before VM or not. And if we're relying on one observation within that muscle, then perhaps we might be missing some of the subtlety or some of the findings of the papers that are showing no difference. Is this down to electro placement? So by, again, having a larger spatial sample, then perhaps we can look at the timing and see whether this is whether there is indeed a trend for VM to fire before VL. So when we're using a standard bipolar or a single differential electrode, we're relying on the placement of the EMG electrodes to represent the timing and firing of the whole muscle, and we might not know this. This may not give us a full picture of the timing or the peak activity within the muscle. As we showed earlier with Perineus Longus, there might be a particular bipolar pair which will be able to generate or be able to show us that peak signal to make sure that we are actually taking the peak signal that we're observing within the muscle. Now, the electrode placement with respect to the motor point is one of the things which has been discussed in the literature, that if the electrode placement is different relative to the motor point, then this can affect the timing. Again, how much this affects the timing is debatable, but as I say, this is a point that has been raised in the literature previously. So a larger spatial sample of EMG signals may be useful. So can the Maze sensor offer new insights into this? So again, what we've got here is two Maze sensors, one on the vastus medialis and one on the vastus lateralis. And again, we have our 4x3 array associated with the bipolar pairs once again. So we can now see, or now get, within one sensor, we can get 12 observations of onset. And we can get another 12 observations of onset here. So this gives us a much larger data set to be confident, if you will, on the onset and offsets of each of these muscles by literally just increasing the number of observations. Okay, so again, what we have here, just highlighting again, this bipolar pair here is associated with that signal, and this bipolar pair with this, and likewise with vastus lateralis with these associated here and here and here and here. So let's have a closer look at some of these signals. So what we have here is one row where we have 4 observations of the onset and offset of VM and VL, with the blue signals being VM and the orange signals being VL. So now what we can do is we can now use the threshold of the background noise or background signal to then create using a 2 standard deviation of the baseline signal. We can then create a threshold by which, if you go over that signal, then that could be considered as an onset, or when it drops below that signal, we can consider that to be an offset. So what we have, in essence, is the onset activations of the 12 differential signals from both VM and VL, and these were calculated for each possible pair, so we can compare the different signals from VM. So the 12 observations from VL we can compare with the 12 observations of VM. And what we get is this, which is showing that we are appearing on average to get an earlier onset of VL versus VM from all of these observations. However, there is some variation, and this is perhaps the important point, that if we were looking at certain bipolar pairs or single differential pairs within VM or within VL, we might be getting a signal here. When we take all of these observations, we get a trend to this being a slightly earlier firing of VL compared to VM. But depending on what bipolar pairs we are comparing, we could get the converse result. So this greater sample perhaps gives us greater confidence in our identification of whether VM indeed is firing later than VL. So we get a greater number of observations across the muscle. This does show some variation, but with VL, generally speaking, on average, firing before VM. Another area we've been looking at is the assessment of back muscles, in particular erector spinae. And as with Perineus longus, there is a challenge here that we have a long, thin muscle, and we are not necessarily always certain where the main body of the muscle is. Are we actually directly on the area where we're going to get that largest signal? So again, I've done a similar thing here where we've got multiple repetitions. This is somebody doing multiple spinal extension tasks, Sorensen test, if you will, pushing up, and we're getting, in essence, 3 repetitions, again, across the 4x3 array of bipolar pairs. And again, if we look at this, then again, similar to what we were seeing with tibialis anterior, what we see is that as we move laterally, so this is towards the center of the spine, so this is the spine's around about here, and as we move laterally, we actually get a reduction in the signal. So this would be arguably us moving away from the main belly of the muscle where we're getting the peak muscle activity. So in this case, with the sense of location, then both of these appear to be over the area where we're getting the maximum muscle activity. These appear to be slightly off. And again, bearing in mind the spatial resolution that we're dealing with here, this, if we're considering putting a traditional EMG sensor on or standard EMG sensor on, then this amount of variation, we could argue that this is potentially present within some of our protocols. So in doing this, we get, again, the larger number of observations, which then allows us to be more confident that we are indeed picking up the peak muscle activity at that point on the erector spinae, or within that level of the erector spinae, because obviously erector spinae is very long and covers an awful lot of the spine. So at that level, we are seeing, going from the spine, going laterally, a decrease as we go more and more lateral, as being off, in essence, the epicenter, that largest activity area. Another thing that we have been exploring is looking at what's going on with finger movements, in particular around the usefulness and assessment in wrist surgery, but also looking at complex. Okay, so let's have a look at some wrist and finger movements. So now we've got a singular maze sensor, and what we are again doing is looking at the 16 channels and then looking at the 12 bipolar single differential pairs. So what we can do is look at the contributions of what the wrist extensors are doing, and then also looking at the finger flexors. So we're going to look at wrist extension and finger flexion. So what we have here is we have the three movements of the wrist at increasing force levels. So we can see the force levels increase. Then we're going to have 3 repetitions of the finger extension. So what we can see from this is that we have the 3 levels here of force, and again this is indicating that one particular bipolar pair is showing the largest activity. So again, this is a spatial resolution. Then what we have is so we have this where the circle is. So this is the wrist extension, and then we have the finger extension here, and then we've got some individual finger extension here. So we're beginning to see that we are able to not only identify the largest activity, but we actually start to see some data here for the individual finger extensions that wasn't present with the muscle activity here, or in a very small muscle activity there. So what we can see here is that the individual movements of the fingers and the hand actually potentially give different signals across the spatial resolution that we have with the Maze sensor. So let's look at this in a bit more detail. So we've just picked out 4 of these signals. So we've got our wrist extension at low, medium and high force. Then we've got the finger extension, again low, medium, high, and then the individual finger extensions here. So it's possible to pick up the contributions of each muscle across the 12 differential pairs. The contribution of the wrist muscle is the greatest at the top and decreases towards the bottom, which is moving medially across the arm. So we can see that as we move from lateral to medial, we see a shift or a change in the magnitudes of these signals. Again, this is relating the movements, so there's 3 repetitions there. And then we have the finger extension. Okay. So let's have a closer look at the individual finger extension. So what we're going to do, we've got 2 taps of each of these fingers independently. And what we can see is that the middle finger, the ring finger and the pinky, we are seeing clear differential signals for each of those. So that's good. But if we look over here as we move laterally, then we're not picking up now the middle finger movement at all with that location. So depending on the location across the forearm going medial to lateral with the sensor, we are in essence beginning to pick up a differential effect of the different finger movements in relation to the different muscles that are being activated. So that's quite interesting that we're beginning to be able to get that sensitivity to perhaps look at finger movement. But what about more complex tasks? So what I'm about to show you is some fun I've been having during lockdown. So we'll call this lockdown guitar. So I'm going to show you what signals we get when we place a Maze sensor across the forearm muscles. Where are we? So across there. So we're going to look at what signals we get from medial to lateral across all those muscles in there. Okay, so I'm not going to play this. I'm going to put my mic on mute so I don't get feedback. Okay, so that's why I'm an academic, not a rock star. For anybody that knows that song, knows Dust in the Wind, Kansas play that at a tremendous rate. That's about half speed, so it's a tremendous piece of music, and I suggest you'll look that up if you're not already familiar with it. Now what we can do obviously is rectify the data and begin to zoom in a little bit on this data set. So what you're seeing here is the first 10 seconds. So you can see when the guitar, the first time I pluck the various strings, and it looks like maybe we're getting different patterns in there for the different finger movement, but we need to have a little bit of a closer look. So now what we're going to do is zoom in on this a bit more. So we've now got finger movement over a 3-second window. Now if we look at these, although they're different in magnitude, which again is important, these two appear to have roughly the same pattern, whereas these two over here appear to be showing a slightly different pattern to these ones. Now this would be very much associated with which fingers are doing what task, of course. So on observation, it looks like these are, when we're not considering the magnitude but considering the pattern, these two are showing reasonably similar patterns, whereas these are showing different patterns, which could be associated with the different finger movement. So what I'm going to do now is I'm just going to now select, not this one, I'm going to deselect this one, because this appears, as I said before, to be roughly the same signal as this one, but with a much, much lower magnitude. So I think that this is not quite on the main belly of that particular muscle, whereas that is, and this could be on different muscles. So let's look at this in a bit. So what we can do from a guitaring point of view, what we tend to do is name these as P being the thumb, then we've got I being the index, and we've got the middle, and we've got A indicating that finger there. Now the pinky is very, very rarely used in fingerstyle guitar, sometimes used to just stabilize against the body of the guitar, which is probably where I'm going wrong, because mine is just kind of hanging in midair. So we're not using this one to pluck any strings. So what we get is, if we look at the data, again we're going to have the guitar coming in, and what I'm showing you here is this is the first pluck of the strings. So we can look at what's going on with A. So the first pluck of the strings is a combination between A, P, and a bit of I. And we get the middle finger, and what we can see here now, if we build up these, is we can see that we're getting different patterns of the different locations within the sensor. So what I've done here is highlighted in blue. So blue is the signal which we're seeing in blue. The orange is obviously the orange one, and the more yellow one is the yellow one. So what we can see here is that we are getting different sequencing, which is interesting because it looks like that we are getting all of them working together, which is how I pluck initially. I'm plucking everything together. But then as we get into the song, we get, in essence, a rhythm of when the fingers are being activated. So they are being activated individually, and therefore they have different timing. And we are seeing different timing across the muscles, across the fingers, depending on where I am within that sequence. Now, what I want to point out is this is just one sequence of me going through one rhythm or one phrase of that guitar piece. So this is obviously only about 2 seconds or 2.5 seconds of data, which just is that first phrase. So this obviously repeats and repeats and repeats. But I wanted to just show you this because this begins to give us this spatial information to be able to identify within a reasonably small space, within a really reasonably small area, we're able to identify complex movement tasks and what the muscle contributions within those small areas for those complex movement tasks. Now, previously we would have had to put perhaps a mini head sensor or a small sensor on each of those muscles, and we may not know that we're on that muscle for sure. So having this spatial picture across the muscle increases the flexibility, or increases the potential for doing analysis of small muscles across a small area. So in conclusion, 16 channels of data providing 12 single differential or bipolar pairs allows for greater spatial coverage, giving potential for further analysis of EMG amplitudes within the muscle, but without crosstalk contamination. We are looking at small enough intraelectrode spacing, spatial to potentially not be getting contamination from crosstalk. Arguably, we're less susceptible to placement issues, placement errors, which can lead to potential underestimation of the peak muscle activity. So again, we begin to mitigate against some of these challenges. We get a greater number of observations of onset and offset within the muscle, which may have further utility in larger muscles when we're trying to work out which muscles fire first. So this also, as the last example was shown, has the potential to unpick the sequencing of closely packed smaller muscles, so we can unpick those things. Thank you very much for listening. It's been a pleasure talking to you. I will now be open to any questions, which hopefully have been appearing in the chat room. So thank you very much.